So today is twofold. We're going to be concluding. I'd like to spend just an extra little moment of time on osteoporosis because I think it's just important to discuss. It's for young folks. You don't think about it. It's time to think about it is now rather than think about it when you're 60, when there's nothing you can do about it. Best way to frame it. A lot of these, it's not necessarily preventable, but perhaps it's more manageable. And if you're going on into a career, a clinical career, or medical career of any type, nursing career, manageable, treatable are good words. Curable is to some extent pie in the sky for a lot of situations. Understand? I mean, the more serious things are, we look for manageable and treatable as being very good words. Okay. Just to understand the nature of what we understand today, very, very much so. Because those are, you can you don't want to give people a false sense of security. Nevertheless, here we go. So this is the last portion of that particular PowerPoint on 6B. You will see I did load just now. I apologize for having forgotten about it over the weekend, but I loaded the joint stuff. I don't know how much is going to be a point of emphasis or if it's going to be included on the next exam when we get to joints. I don't know. I might put the arthritis nugget on it. I think that's kind of important too. But all the structural stuff, that stuff, I'm going to have to cover it because you didn't do it in lab. And this is labs. This is it. Yeah. So you guys may not be listening to me. I understand today, or why would that be any different than any other day? So I'm in a good mood. That was the closest to a low stress Steeler game ever. Nevertheless, okay, here's what we look at. So we call them, basically, typically they're framed as metabolic bone diseases. But bone disorders is fine. And really, it falls into, arthritis is a whole different issue because then you're dealing with a joint. You're going to see the complexity a little bit today. When it comes to the bone, it's really about most of the time it's about, are we making enough products? And a lot of it has to do with calcium, as you're going to see. So assuming that a person does not have a genetic dysfunction, there's an oddball you don't have to know because it's called osteogenesis imperfecta. It's a genetic disease. I've had patients with this disease. And so if in a clinical career, if you encounter someone, it's not that rare. Okay. It's not like a once in a lifetime type of thing. And you don't have to write it down. Osteogenesis imperfecta means it's a disorder of collagen, and the collagen and the bone-related materials don't get laid down. And these folks are become very short of stature, bones fracture easily, and collagen is the most abundant protein. It's characterized into, if you ever run anybody with the white of their eye, looking kind of a bluish tinge, it's called the blue sclera. Keep that in your hip pocket in case it's a very, very interesting. And I had a very memorable patient who was older, 50-ish, I guess, when I saw him. And that's odd because he was very stature. And he said, I have osteogenesis imperfecta. And all of a sudden, I didn't even notice the blue sclera. And then I familiarized myself with it. So there's some oddball disorders of bone. These are the most common. So typically, this is related to either vitamin D and calcium. And so really malacia, if you ever see the term malacia in a context, it means softening. For instance, kids get a disorder, and even adults get a disorder called chondromalacia patella, where the patella, your kneecap kind of rides off to the side because of an imbalance in your leg or your feet, and it causes it to weaken and soften. It's nasty. It's one of them, maybe the second most common cause of chronic knee pain. So what happens? Bones are poorly mineralized. You can't get the calcium into your bloodstream. You can't get it into the bone. The osteoid is produced, but the calcium salts are not adequate for deposit. Soft, weak bones, pain on weight bearing. So that is typically one of the two. Either we don't have the vitamin D or not. And then this, or the dietary calcium. Comment on that in a second. This is how it's characterized in adults. Remember, your bones are constantly, basically, reproducing themselves. Rickets, a disease you very, very rarely see. if you ever go, if you're in if your life's work takes you to an area where you're in a poor area or an underserved area, a foreign country, a war-torn area, all of that stuff, you know, that where there's not inadequate nutrition and inadequate health care, this is when it may show itself up. Because in this country, it's very rare. Okay, rickets is the osteomalacia of children, bowed legs, and other bone deformities. The bone ends are enlarged and abnormally long. So what we see with rickets, and I remember it acutely seeing, I don't know if the x-rays clicked up. It's almost like the end, if you look at the tibia, it's almost like you'd have something that looks kind of like this. Tibia widens at the top, in that area, the upper condyles, because start looking at joints. And then it's almost like the epiphysis should form those condyles like a circle. So it almost has, it looks like that. You imagine it looking like the opening of a truck. So that's one of those really odd little things. Rickets. One's here too. I just got one here. And what we did about that, this was something that was seen during, certainly really manifested itself during the Depression. You know, we're talking almost 100 years ago. Starvation in this country. If you have no idea, I have no idea. My dad had a real good idea because they were destitute and starving back in 1931. So I mean, you know, I got that picture from from the horse's mouth, so to speak. Nevertheless, what we did is basically we took care of it in milk. Vitamin D enriched milk, calcium enriched milk. Milk is a great source of calcium, and almost all the milk you have, just look on the label, it's got vitamin D. So you basically have addressed the problem in one fell swoop. The difference in how the bones appear is when bones have matured, you're not worried about the growth plate. Here, in rickets, it's the growth plate. So typically kids would have bowed legs, they couldn't stop it, and you particularly would see it at the knee, this sort of unusual circumstance where the epiphysis really didn't even develop or was able to really support a lot of weight bearing. That's the sum and substance for that. The big one, osteoporosis. Osteoporosis is a name of, when they say a group of diseases, there's a number of things that cause it, what we would call risk factors that are there. And what's interesting, even though the matrix is somewhat normal, the bone mass declines. Okay, and spongy bone, particularly in the spine and the neck of the femur, is most susceptible. So compression fractures, pathological fractures, look where they occur most often. That gets back to the same thing. Typically, when you have an older person starts to develop a sudden onset of back pain, the first thing you would look for in that is, has a disc collapsed or started to collapse, have the intervertebral disc shifted, have the vertebrae collapse or started to collapse. And again, as I told you, the hip typically goes and the person falls down, not the other way around. And that femoral neck, you remember looking at that illustration I showed you a couple of times, all that weight's coming down right along that area. So it's really significant in that regard. So, and this is, it's a fabulous slide. Normal bone, and take a look at that. Moth-eaten bone, osteoporotic bone, whatever you want to describe it. And the tragedy of this is you don't know that. You would not see this on an x-ray, reflected on an x-ray, until the bone was about 75% gone. That's what the body does. It doesn't begin. There's so many safeguards that are involved, and some of them are just the fact that we can't identify them early. With older technology, when we just had effectively x-rays, we didn't have a lot of, now there's a number of scans that can be done that can detect the mineralization of bone without just having to rely on an x-ray, because when I see the x-ray, there ain't nothing you can do about it. So most often, aging and postmenopausal, women clearly predominate. Look at the numbers. 30% of women age 60 to 70, 70% by age 80. Estrogen is the big player. So this is clearly dominates in women more so than men, not exclusively though. And you're going to see this with a number of disorders, as you said. When we start talking about what we call, and it's in the next section, you talk about an immune, but we talk about rheumatoid arthritis. By far and away, women predominate. 3 out of 4, 4 out of 5. My hands, 4 out of 5 cases I've seen. So bone density. And what happens is, as estrogen levels drop at menopause, women run a much higher risk. And men are much less prone because testosterone, ordinarily in men, is produced through the duration of their lifetime. Certainly not as much as when they're young, as when they are older, but absolutely through their entire lifetime. And so women typically at menopause, whatever the age is today, the average age, some years ago when I looked the number up, at about 53, 54, things like that. But it doesn't preclude any women with ovarian dysfunctions. And given the amount of children that are being born who were able, with the process involved in vitro fertilization, I suspect that number is going to rise. And I'm sure they're going to study why there's a lot of ovarian dysfunction. More on that. I mean, the last 4 grandchildren were all conceived IVF for my family and my wife's family. Additional risk factors: osteoporosis. For all of those, exercise, diet, calcium and protein, smoking, looking at the genetics of it. Okay, other conditions, diabetes plays a role in it, and diabetes is an enormous player. The one disease you can't know enough about, if you're going to be in a health-related field, is diabetes, thyroid, alcohol, certain medications, etc., etc. The big deal is adding up all these risk factors, and it's just a matter of assuming you have the luxury of having a biological parents and grandparents that you can look at and ask and see what's going on with their lives. You'll have an idea whether you're prone to it. It's not a slam dunk. Genetics aren't a pure science like that. And again, the reason I phrase that, my kids are all, we don't have any way of identifying them genetically because they're all adopted, and adopted kids, you just don't get lucky with stuff like that. Sometimes you do. But most of the time the records are pretty hard to find. That's what you got to be looking at. So here's the story is interesting. My first wife, I told you, 5 feet and a half inch tall. Okay, now has lost a couple of inches. She, not only was she shorter stature, which is a predisposing factor, her coloring, her general facial coloring, folks who are very, and forgive me, I don't mean to offend you, blonde, Nordic looking, less predisposed than people who have more Mediterranean, Middle European or Eastern European descent. Okay, so her skin tones are more tanned real easily, that type of stuff. So more like in that sort of Italian, Spanish, that sort of more southern Mediterranean appearance. They're much more predisposed to it. Start with it, shorter stature, distort. She was prematurely menopausal she ceased, I would say, early 30s. So she started herself with the aid of a wonderful OBGYN on estrogen and progesterone supplements in the early days. Still ineffective. Out in the sun all the time. Exercise as much as possible. Very active physically. Very scrupulous diet. Lots of supplements. Then, if it's going to happen, it's going to happen. You're trying to mitigate. You're trying to limit the likelihood of the problem. So for all of you, any of you, see what the deal is. Anybody have problems with it, address it now. I still recommend, and it's recommendations, vitamins, I was a doctor once, now I just play one in school. Vitamin D, calcium supplements, I would do that. Exercise, sunlight, good diet, all that kind of stuff. Basically the lifestyle choices. If you're going to do something that's adverse, moderation. So voila, all that good stuff. Like I said, am I always going to be osteoporotic because I went out of beard? No. Again, it's all about moderation and things like that. So weight-bearing exercise, calcium and vitamin D. The medications have been limited. They've been looking at things like calcitonin, higher doses for extreme cases. They used other ones. It was basically a drug that tinkered with phosphate. If it caused the kidneys to retain more phosphate, theoretically they would bring in more calcium as well. They were marketed a lot, but they are very difficult for people to tolerate. I think they're bisphosphonates. Don't quote me on it. We'll probably see that subsequently. And then this is an oddball. Most people don't see it a lot or don't recognize it. It's called Paget's disease, and really, it's just odd. So, and we see it in adults, very much, middle age and above. Could be viral. Again, here's the calcitonin, the bisphosphonates. You're trying to get more uniform absorption of bone. So, I mean, it's. I don't think there's, and it looks like there's areas where there's a lot. It's like a lot of bone here and not much bone here. So it's very spotty. But unfortunately, the whole bone is weakened. I remember we had a case with a hip fracture with Pagetic bone. Interesting, where if you like names, Paget's disease is another name. It actually is a form of breast cancer of the nipple, which is not, my mom had it, so it's not that terribly rare. And typically, if it's caught early, it's just excision. It doesn't require all the radiation and stuff like that. You're very fortunate. Very fortunate in that regard. And that's what I mean. So here you can take a look at normal versus, you get areas where it looks like there's extra bone, but in the areas where it's not, it's quite weak. It's really an odd one, to tell you the truth. See, you're done with bones. Don't have to thank me. It's all part of the service. So I sent these to you this morning. Okay, joints and joints. I also sent you the Welsh whole chapter of joints. I put that on the, you can find it on the blackboard. And these are the messages, so everybody should have these things. Bad news, I do not have an outline for this. So you're going to have to do it yourself. If I can do it, you can do it. Let's see. Did you guys all stay up late last night? This is, you're really not, you need to see some bright faces. Should I turn the lights on? Will that help? You gotta stop drinking all night long. Okay. So you didn't have any of this in Zippo? None, nada. No bueno. Articulations. The word articulation is where bones come together. And by definition, we call them joints. Get the notion out of your head that joints have to move. They don't. You looked at that skull, all those sutures, you remember coronal, sagittal, lamboidal, squamous, all those. See, I took that course. Okay, they don't move. So we classify joints based on how they're constructed and whether they move or not, or to what degree that they move. You're going to see this is a classic classification that you should learn about. Again, I do, because of the overwhelmingly fast lab, I should have anticipated with stuff that was just not going to be there, but that's okay. So structural, are they made out of fibers? The sutural joints, okay? Tiny collagen fibers are holding those bones together. As the bones mature and the fibers mature, they are pulled together, and surprisingly enough, those are the ones that don't move. You're going to see the next term, I'll show it to you here, sin, S-Y-N, in this case, sin, like in Spanish, S-I-N, would be without. Synarthroses, immovable joints. So surprisingly enough, fibers, and as they shorten, the reason that those fontanelles, those areas where the skull could move in babies before they're born or when they're born, and up until maybe age 2 when they finally seal completely, is the fibers basically contracting. Okay, the bones enlarging and then the fibers maturing as well. Pulls it together. Got it? So it doesn't matter what classification. I mean, you got enough on that test. I'm not going to sit there with a matching with your, which is the way I would do it ordinarily. You don't have to thank me. So they don't care. Cartilage in the joints. Where we have now, understand a cartilaginous joint. This is not when we later in this chapter when we look at the knee, looking at the cartilages in the knee. That's not by definition a cartilaginous joint. Cartilage in a joint, basically cartilage makes up the joint. The best area to be able to look at the intervertebral discs. Okay, those discs between the vertebral bodies The symphysis pubis, where the pubic bones join, okay, those are cartilaginous joints. They are, and you'll see the term here, amphi, meaning some, I don't know the exact derivation of the word, some movement. They give a little bit. I mean, in the pubic symphysis, there are relaxins that are secreted during the birth process. It moves a little bit more. Okay. Intervertebral disc, that adds to the remarkable ability to have with all these bones that don't move very much and all those little joints. You're being able to, twist all the way around. Imagine that, the kind of stuff that you can do, how much flexibility that a lot of people have with their backs and things like that, whether they're bending, stretching, twisting, etc. Think of, really wonderful dancers being able to do that. And you train for that, obviously. And the one we're going to spend all the time about, this bad boy, the synovial joint. These first two do not have a joint space. They do not have any joint fluid. So that makes them very unusual. The synovial joint is the main joint when we talk about arthritis. It's all about the synovial joint. It has the capability to move, what limits its ability to move, what causes it to be inflamed, what causes it to be damaged. How does that all play out? That's the synovial joint. So it's a really important one to understand. And that's really where the time consumption. When you hear about joint fluid, that's the synovial joint. So although the knee, for instance, has cartilage in it, it is still a synovial joint because it moves freely. And indeed, that's what this means. Diarthroses means freely. So structural classifications are more clear cut, so we use those, and I buy that. Who needs these terms? Arthro, as you undoubtedly have already surmised, is the sort of the root word for joint. Arthritis, inflammation. Arthrology, the study of joints. So, fibrous, dense fibrous connective tissue, no cavity. Most are immovable. It depends on the fibers. For instance, okay, the example in this part of the classification is what's called the interosseous membrane. Is that name ringing a bell? Between the radius and the ulna and the tibia and the fibula. Between the radius and ulna, it's designed to move. The two bones grow to move over each other. The head of the radius and something called the radial notch in the ulna. Is that on the old anatomy test? See, now you see why it works, why it's important. Okay, the tibia and fibula, no bueno. I'm having a no bueno day. Son probably told me. It's okay. Call me on it the next one. So understand the tibia and fibula are not designed to move in that fashion. We can't, those two bones don't pivot. So not all of these are created equal. And that's when you do this, when you're into the anatomical science, and particularly for me, you're someone who treats things orthopedically, you become very aware of these things over the years. So going back there, depends on the length of the fibers. And so we'll look at three. The sutures, just mentioned, syndesmoses, you'll see that in a second, okay, and gomphoses. So here they are, the skull, growth during youth, the connective tissue fibers allow for some degree of expansion and eventually do not. Okay, eventually they hold things quite tightly. And we see this process, which they call synostoses, not that you have to know it, basically is those sutures becoming all bone. And it's one of the ways forensically you could tell how you could age a skull, things like that. Bones are very useful forensically in finding out how old it is, things like that. So movable joints join the skull into one that protects the brain. Okay, and if they get all bony, synostoses. So voila, you saw those. Not going to do any more with it. Again, fibers, they're holding it together. Syndesmoses, ligaments or bands of fibrous tissue. Short, little. This is, you're going to see the illustration in a second. This is the reason why we distinguish between the high ankle sprain that you hear about in sport and your basic ankle sprain. Okay? And why the time? Long fibers offer a larger amount of movement. The interosseous membrane and the radius and ulna, again, movement. That is a syndesmosis. Whereas this is the distotibiofibular ligament. So it's distal or inferior. And this ligament is super strong. When you have an ankle sprain, okay, the part of the ankle that sprains is down here. This is the ankle joint. Actually, the sprain is below it. That's the typical what you see when we talk about sprains in this chapter, what's called an inversion sprain. You're walking, kind of hit something, you kind of roll your foot, the heel goes up toward the heel, and sole goes up toward the inside. It's all on the outside, under the fibula. There are three ligaments there, that's what's involved. Those, they can be very severe, you can get a broken bone out of it. All those bad things can happen. This is different. The severity here, probably more often we would see this kind of thing, again, when we see it in sport, where the foot is fixed or can't fit or gets stuck in something, and then there's trauma from it, whether if you imagine skiing or in a football game, like that. And what happens is, remember your bones, the talus, remember the calcaneus on the bottom, the talus is up top, head of the talus basically rammed into that and separates it viciously. In the old days, we used to inject dye into, before we had MRIs, CTs, it was called an arthrogram. We would inject dye into the joint, take x-rays, and see if the dye stayed in the joint or if it went up that way. If it went up that way, high ankle sprain. And it was really an elaborate procedure to have to hold them together. We had to take a screw and go through the tibia and into the fibula to hold it together. Now they band it with a strong band that has a tiny amount of give, part of the healing. So and I forget what the name of the procedure is. That's the modern technique. Okay, last one, gomphosis, peg and socket, peg and hole joints or teeth. That's the periodontal ligament. If you ever have had a tooth out, okay, that's the hard one to get. You'll see it there. That holds the tooth in the socket. Is down here. So technically, that's a joint. It's not supposed to move. Obviously, if new teeth are coming in, like secondary teeth coming in, it's going to weaken. And again, there's a variety of reasons, in adulthood that cause that to be a problem. Cavities, things like that, have to do root canals. And sometimes if you have to extract the tooth, that's the hard part to get out. So hopefully you've never had to go through that. That's it. And you're at the, feel bad for you. You know what age you're in. Wisdom teeth, molar 3 age. I can't tell you. Mine were out Easter of my freshman year in college. And that's common. A lot of third molars go out when you're at the age most of you are at now. Cartilaginous joints, 2 types. Okay, no joint cavity, not a little bit of motion. Okay, cartilage between the bones. Yeah, I'll agree. Most of them are immovable. The epiphyseal plate, by definition, is one of those. Okay, the first rib and the sternum. There's a certain amount of motion that's there, and part of that assists us in our ability to expand our chest when we're breathing. They're showing it to you here, the joint between the first rib and the sternum. I mean, I think there's a little motion. They don't necessarily agree. Doesn't matter. And then lastly, the symphysis. This is the one. Hyaline cartilage, also present as articular cartilage on the bone surfaces. These are the ones that definitely move, the intervertebral joints and the pubic symphysis. That's all the straightforward. Why I'm telling it to you and why you should just not say, well, I probably won't give. It's the code when the instructor says, well, I'm not going to test you on it, ears get shut off. Don't do that. Because somebody might, that's the kind of question you see on a board exam, on a licensure exam. They'll pull this stuff. They're like, oh, I wonder if we got a good one here. Boom. And the next thing you know, you go, I know they mentioned it. I'm not doing it. I passed the test already. Showing it to you, synovial joints. Let's see what I can do with this. I got to turn the light. Sorry. It'll be fun. Split in two ways. So here we have the basic construct. Very generic. Couple of long bones. Doesn't matter. Effectively, cartilage at the ends. That's what's left of the hyaline cartilage. That's what's left of the way bone was made. There is a definite space. Obviously, I can't draw it to scale. It's small, but finite, meaning it's measurable, and it's definitely there, and it's filled with fluid. External to it, remember, on the bone, you have periosteum here. But it becomes, as it gets close to the joint, it lifts away from the bone, and it becomes what we call capsule. Capsule is a very unique structure. It's very thick and fibrous on the outside. And on the interior, effectively it has simple squamous cells that secrete joint fluid. So that's the internal one. I mean, there's obviously some soft tissue in there in between the two, but I mean, trying to give you an idea of the general construction. And I would say the same thing over here as well. So again, it's continuous with the periosteum, but as you get closer to the joint itself, it lifts up. And interestingly enough, the way the fibers are laid down has a very distinctive pattern. I mean, I go back to the stuff I've told you about a number of times, fan folding it. Look, your joint's got to be able to move. It's not a fixed structure. I mean, here's my joint at rest, with, the anatomical position. I mean, if I do this, this part has to be able to compress on itself. This one has to stretch. Accordion pleats. That's how that works. We see them. We operate on them. To give you an idea, if we make an incision, expose it down the middle like that, or down the middle like that, and when we come back to close it, we open it up, and then when we close it, we would sew it right along that area. Bring the fibers back together, because you can actually see the pattern in the joint. That's the amazing handiwork on the interior of the body. If you don't, it's like anything else. It's like if I button the shirt, in the morning, and all of a sudden I have a little cockeyed here. Same thing in the joint. It doesn't work the same. One day I'll have the inside out shirt. I do that like once a year. My wife just kicks me. Then one day you go, oh, Lou, have a nice day. Oh, by the way, your shirt's inside out. Should I just wait? These jokes used to work. But, don't start. It's okay. So, moving on. Freely movable, 6 general features. Bursa and tendon sheets we're going to get to. Okay. Stability. I disagree with their... Again, whoever writes these PowerPoints probably never operated on joint. Just a guess. Okay. And movements you have to understand. There's things that are important to understand. The 6 types of joints and the movements that are part of it. That's an important part of this. Okay. Articular cartilage. Hyaline cartilage at the end. Does it prevent crushing? I doubt it. It's about 1/8 of an inch thick. I don't think it's going to keep. Oh my God, I fell from height. No, it's not going to prevent crushing. Synovial cavity, small, fluid-filled, potential to me, I wouldn't have used the word, means when there's extra fluid, it can expand. When there's not enough fluid, it will contract. I'll buy that. Okay? And it's unique to synovial joints. I'll buy that. The fibrous, dense, irregular connective tissue, the same thing. Periosteum is made out of. The same kind of stuff the deep dermis is made out of. intersynovial membrane. Again, wherever you have simple squamous cells, any type of lining cells, you always have loose connective tissue. That's really where its blood supply comes from. That are there. The fluid. Hyaluronic acid is one of the things that Matrix is made out of. Hyaluronic acid is basically sort of like, think of it as a protein and sugar compound. And what effectively it does, it gives the viscosity. Joint fluid is it's straw colored, it's relatively clear, and there's a certain element of stickiness. Like if you motor oil, you got some on your finger when you're dipsticking your car to see if it's got enough oil, and you can kind of do that with it. There's a certain amount of stick to it. That's what viscosity is, the level of thickness. So that creates it, the viscous, and it does imply a certain amount of slipperiness. And so that's kind of where plasma is basically just a solution. The addition of the hyaluronic acid certainly plays a role. Yeah, for sure. Okay, lubricates and nourishes, I'll buy that. Yes, there's white blood cells in there. We have scavenger cells like that in a lot of areas. And then the other part about this that's interesting as well is when you start looking at ligaments. Ligaments, typically, we learned about epicondyles, right? Epicondyle to epicondyles or a ligament. Epicondyle to epicondyles or a ligament. For instance, what I've done here, these are both ligaments, and every long bone has ligaments on either side. Since they're both there, we have a name for them. They're called collateral. Difference is, and you have ligaments that can be on the bottom, you have ligaments that can be on the top, along the sides, other ligaments. The way we had to decide what they're like, okay, or an additional classification, most of them are frankly part of the capsule. There's just thickenings in the capsule itself. The capsule. Some actually are outside of the capsule. If I turned around and did the same drawing here, ligament actually could be exterior to it. In other words, you could actually, you could put an instrument and separate the two of them. Even if it was delicately thin, there's still space. And even some ligaments are intercapsular. Understand that there's a joint that has all three of those. That's right, it's the knee joint. Okay, that's why it's so complex. It has intercapsular joints. We will learn famously those are the cruciate ligaments. Extracapular, outside the capsule, during the fibular collateral ligaments in the knee, has that, and capsular ligaments, the medial collateral. We haven't talked about the other complexity of the cartilage. It was the meniscus. You're watching the Steelers game, their great special teams guy, who they went out. When you see a non-contact injury like that, and it flexes like that, I'm betting that's appreciate it. Just in case. Over time. I mean, a guy missed a game in missed 2 games in 5 years, something like that. Just saying. So it gives you an idea, and nerves and blood vessels and joint position and everything like that. And that's part of what your nervous system does. I mean, there's sensors everywhere. And again, all of that, you'll come to know that that's fed into your brain. So like if you close your eyes, I mean, you know if your arm's flexed or not. You know if your knees are flexed or your legs are straight. You know. That's called proprioceptors. We'll get to that in the nervous system. It always tells you things like that. I mean, if you don't, that's big trouble. And obviously nerve and blood vessels, that sort of part for the course. And this gives you a little idea of the extent, I think, from an illustrative standpoint, of how much space there is in here. You get a pocket here, and these little pockets are kind of interesting. When people get arthritis, sometimes little bits of calcified cartilage get stuck in those pockets, and the joint will not move. I've had a lot of elderly patients over the years. I can recall one distinctly, and this lady, we're examining her and treating her, and all of a sudden she's ready to get out of it. It's a chair that will lean back or stretch out. She couldn't, her knee stuck. Thank goodness, 15 minutes later, finally the spasm relaxed. I mean, her knees were terrible. I treated her for 25 years. I knew it very good. So, and someone got stuck in there. Other things, fatty pads. So a lot of areas have natural cushioning that are there. So you'll see joints that have pieces like that. The knee again, the shoulder, relatively complex joints, two of the more complex joints in the body. They will have structures like this. And here, articular discs are not only in the knee. There's a couple of others that are significant. So fibrocartilage separates the articular surfaces to improve the fit. So, I mean, you look at the bones. The round head, femoral condyles, that rather flat area on the knee, they're like little gaskets, the menisci. And they deepen and create a socket. They also increase in a certain amount of motion. We'll talk about that when we look at the knee. Two other joints. One joint that gives you a tremendous amount of range of motion. Okay. Your shoulder, only thing that attaches your whole arm assembly is here. Sternoclavicular joint, where the clavicle hits the sternum. You just do that and feel inside. There's a cartilaginous disc. Little bits of cartilage like that, a disc like that improves range of motion. And the other one is a very famous joint that's easily dislocatable. Easily dislocatable joint in the body, the temporomandibular joint. There's a piece of cartilage there. When people have TMJ, it's because the cartilage is in there. Good news, it'll let you move your jaw side to side, up and down, front and back, all that good stuff. Bad news, if it's messed up, all of a sudden it gets locked open. TMJ dysfunctions are no picnic for people, unfortunately, who have them. See, it's a good news, bad news thing. Simple joints have less stuff to go wrong. When you start putting in the knee, cruciate ligaments, ligaments that are part of the capsule, ligaments that aren't part of the capsule, and add a couple cartilaginous discs, you have more stuff that can break. Think of it that way. More stuff that can go wrong. Human body is no different than anything else. More doesn't mean better. More may increase its level of function, but it increases its level of problems if it breaks down. Harder to fix. So, okay, and now these are interesting. We're born with a lot of these. They are part of your knee has them, your shoulder has them, your elbow has them, the back of your heel has them, where the Achilles tendon inserts into the bone. They're called bursal sacs or tendon sheaths. A bursal sac is Mother Nature's sort of protection against friction and pressure. Whenever hard things rub against each other, okay, a lot of times they're there just for the purpose to cut down friction and pressure. And so they're little bits of extra synovial fluid in little pouches. They describe them, I don't know, ball bearings that act as lubricating ball bearings. Okay, if you want to call it that, that works. My knowledge of cars is limited to the keys I have in my pocket. I have a son who builds them and takes them apart. It's just the way it is. I was not gifted with that. So not strictly part of the joint, but closely associated. Bursae, where anything rubs that could be firm against each other, and sometimes they'll form even if they're not there normally. And lastly, tendon sheaths. Tendons that go around bends. This is a very famous one. You hear about somebody with a ruptured biceps tendon. This is what's called the long head of the biceps. It goes through, you remember on the humerus, you had that intertubercular groove? Greater tubercle, lesser tubercle. See, this is where it comes in. Okay. That groove. And what happens is this tendon goes all the way up and basically inserts into the top of the glenoid. That's that socket that really, look, this is much of a socket on top of the shoulder, so the shoulder moves so much. This is, they call it a super stabilizer. And so when you have a ruptured biceps tendon, the tendon didn't tear apart. It ruptures, it pops out of that enclosure. And the enclosure is a tendon sheath. Tendons going into your hand or into your foot, like this, when they go around the bend, there's a sheath. There's like a liner they fit in. If they're cut, you have to make sure that they're under tension. They'll be like, can you pull that down? They'll do that because they've done it to me. You see one of those in surgery, learn a lot about not having it happen again. Things in the body are under tension, so they snap back. The tendon's not elastic, but the tissue holding it is elastic. And so they have to, when you put them back in, you have to make sure they go through the right sheath. So there's a certain complexity about that. I did a lot of lengthening and shortening of tendons to do mechanical stability. We learned very early on, we call it tagging the tendon. You put a little bit of suture in the tendon and a clamp and held it there on the table, on the sterile field. That way, if you accidentally cut too much and the tendon gave way, which it could, you can still fix it fairly easily. You don't have to go fishing for it. I'm trying to acquaint you with the intricacies of just how complicated things are when you're starting to remodel and revamp them inside. It's not easy. So that's part of it. So this is the tendon sheath. Typically, whenever a tendon goes around a bend, there's a sheath to prevent that. I finally remembered his name. Steelers had a guy in Bill Cowers named Barry Foster, ran for 1,600 yards, led the league in rushing. We thought he was going to be all world. He ruptured a tendon on the outside behind his lateral malleolus. Never was right after that. The tendon didn't rupture, it popped out. There's a little groove behind the lateral malleolus on the fibula that popped out. He tried multiple people to try to fix it. Didn't work. I talked to one of the orthopedic surgeons who had seen him in consultation. Because our daughters were in a group together. Oh my God. So, I mean, there's a lot of this stuff that goes around. Here's another example of the bursal sac. We'll leave it here because this is my major issue with how they're misleading you. So we'll stop at factors influencing stability of synovial joints. Thank you.